Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. This is Cardiology Board EKG Interpretation. On our YouTube channel, we have more than 300. On our YouTube channel, we have more than 300 cardiology lectures, starting from basic science all the way up to 2022 ACC/AHA guidelines, with lots of charts and useful information. We would encourage you to please do watch them and subscribe to our YouTube channel. So let us continue. I have prepared a cardiology rotation manual which contains 250 pages of very pertinent information, starting with the history taking, physical examination, what tests we order and how we follow these patients, and all the different protocols that are used for various situations. You can get a free copy of this one. At the end of this presentation, I'll tell you how you can get a free copy of this one. I also have an EKG book which is on Amazon, and I have created a video for each chapter in this book, so you can watch those videos on my YouTube channel. So let us begin with the feature presentation, that is Cardiology Board EKG Interpretations section that involves ST and U wave abnormalities. If you are preparing for the cardiology boards, you should be familiar with this answer key that is provided for interpreting the electrocardiograms during the EKG section of the cardiology boards. And I have done a general overview of this answer key sheet on a separate video. You please watch that. I have also created separate videos for each one of these segments with actual examples, so that you will be familiar with what to look for when you are sitting in an exam hall or when you are seeing a patient at bedside or in the clinic. The focus of this presentation is going to be ST-U wave abnormalities. This is what we're going to be focusing. And in the previous presentation, I made a very extensive evaluation of myocardial infarction based upon the anatomy, based upon the leads, based upon the age. Please do watch that one. And in the next video, we're going to be talking about pacemakers. That will sort of complete all the different segments of the EKG interpretation for cardiology boards. So let us focus in this presentation on ST-U wave abnormalities, and let me expand this a little bit. And so some of the things that you need to be familiar are these things, because if you know these things, then that's all you're going to be tested. So you need to know what is a normal variant, early repolarization. What are the characteristics of early repolarization? Normal variant, juvenile T waves. Juvenile T waves. So there may be a tip in the history if it says juvenile. Non-specific STT abnormalities. We're going to look at what are non-specific STT abnormalities, what are pathological STT abnormalities, what are secondary STT abnormalities, what are hyperacute STT abnormalities, and all of these, as you can see, suggestive of myocardial ischemia. Myocardial ischemia means it is not an acute infarction like myocardial injury, where you see ST elevation and hyperacute T waves. Myocardial ischemia refers to changes associated with ST depression, T wave inversion, whereas myocardial injury is characterized by these hyperacute T waves with ST elevation. Abnormalities related to electrolyte imbalances, potassium, sodium, potassium, calcium, all these things. Some of these have been covered in the miscellaneous group, miscellaneous group that was done. Some of those have been covered under this miscellaneous group, like hypokalemia, hyperkalemia, hypocalcemia, hypothermia, all these conditions. So you can watch that video. Then we have STT abnormalities secondary to hypertrophy. Left ventricular hypertrophy with strain. So you should be very familiar with the changes that are associated in patients with hypertension or aortic stenosis. Then we talk about prominent U waves. So if you get familiar with these, it's not very difficult, because it's just a matter of systematically analyzing these electrocardiograms and trying to see which category do they come under. You can easily identify early repolarization, pericarditis, or you can identify myocardial injury. you should be able to identify myocardial injury. The electrolyte imbalances sometimes can be tricky, but the history may be your clue. And myocardial ischemia is, as I said, ST depression or T wave inversion. Hypertrophied secondary changes or discordant STT changes in the direction that is opposite to that of the QRS complex. Prolonged QT interval, a lot of times it is iatrogenic, created by drugs that are given to control arrhythmias. So let us look at some real examples. Here is an example of what looks like a sinus bradycardia, and we have like a sinus beat here. We have little downsloping ST segment with a sort of a biphasic T wave. So we are seeing biphasic T wave here in the inferior leads, and if you come to the lateral leads here, there may be a suggestion of a left atrial abnormality, but if you can see, the ST segment is elevated, the T waves are upright, but the most prominent feature is the increased voltage here. The increased voltage meets the criteria for left ventricular hypertrophy, and along with that, we have the downsloping ST segment with a inverted or biphasic T wave. These are STT abnormalities related to the left ventricular hypertrophy. And in patients with left ventricular hypertrophy, not only do we see this symmetrically inverted T waves with downsloping ST segment, we also see ST elevation and prominent T waves in the anterior leads. This is not an acute injury pattern. This is sort of a secondary changes to these ST depression and T wave inversion seen in the lateral chest leads. So obviously we're going to see in lead 1, AVL, V4 to V6. And combine that with increased voltage and perhaps a left atrial enlargement, you are looking at the left ventricular hypertrophy with strain and STT abnormalities related to the left ventricular hypertrophy. All right, let's look at the next example here. Here we have a sinus rhythm, maybe low voltage in the limb leads. Then as we come around, the obvious finding is ST elevation here. The question is, whenever we see ST elevation, we have to talk about, is this early repolarization? Is this pericarditis? Is this acute myocardial injury? Or is this related to hyperkalemia, early stages where there is tall peaked P waves? If you're looking at an EKG like this, we have to say, what is the history? 45-year-old male with a history of hypertension. So this patient hasn't come with chest pain, fever, or malaise, or anything like that. So we are looking at what could be just a benign early repolarization. And sometimes we may just see diffuse 1 millimeter ST elevation with a J point lifted from the baseline, like as we see here, with like a concave ST segment with the upright T waves. And this can be seen in multiple leads. Generally, they are benign, and if you have previous EKGs, they may have similar changes. But if the same person was to come with chest pain, obviously you would be concerned about, of course, pericarditis. And here's an example of an 18-year-old male with a history of shortness of breath. We have a normal sinus rhythm. The axis is okay. The atrial P waves are okay. QRS complexes are okay. The only thing that we see are like inverted T wave in V1, V2, V3. These are shallow inverted T waves. And given the history, this is an 18-year-old person with the shortness of breath, was probably having a school physical exam for sports. And you look at this electrocardiogram, and this is considered to be a juvenile T wave changes. If you are concerned beyond, or if you hear something in the heart, then an echocardiogram may be able to ascertain if this person has any structural heart problems. But there's no evidence of hypertrophy. There's some increased voltage because of the age, but the P waves and the QRS complexes, they all look pretty normal. Let's move on to the next one here. Here we have a 26-year-old male with fever, weak chest pain. I've been having pain for 2 days. I don't know if it's here, it kind of moves. When I move around, sometimes it gets better, sometimes it doesn't. Now we see ST elevation here, ST elevation in the lateral leads. it almost looks like the patient earlier we saw with early repolarization, but the changes are much more dramatic in this person. And one of the key factors is to look for the PR interval, which is depressed in patients with pericarditis. More than likely, they're going to give you an EKG with ST elevation, which may have a PR depression, and that is your key. A point in the history, a point in the electrocardiogram to pinpoint whether this is early repolarization or whether this is acute pericarditis. Always look for PR depression in patients with pericarditis, or if you see PR depression, then consider pericarditis as the most likely diagnosis. And J point elevation, we see that in both the early repolarization and also in pericarditis. Okay, let's see, 60-year-old male with a history of chest pain, hypertension. So now we have a patient with an acute presentation, chest pain, hypertension. We have a sinus rhythm. The axis is almost 90 degrees because this is isoelectric. What is going on here? We have T-wave inversion here, T-wave inversion, T-wave inversion, T-wave inversion, T-wave inversion. We have diffuse T-wave inversion in a 60-year-old person with a hypertension. And there is some evidence of left atrial abnormality or enlargement. There is not enough voltage criteria to say this is left ventricular hypertrophy. So these are not secondary changes to left ventricular hypertrophy. There's also loss of R waves anteriorly. It is hard to say. We still have some tiny R waves here, whether this is lead displacement or whether it's an old anterior myocardial infarction. But nonetheless, all these T-wave changes suggest left ventricular ischemia. So if the person comes with chest pain and has this EKG, along with elevated biomarkers like troponin, then you're talking about non-transmural myocardial infarction. If the enzymes are normal and if the patient has these changes, and if these changes are new compared to the previous EKG, then you're talking about left ventricular ischemia, and I would particularly be concerned about what the EKG R waves look like in the previous EKG. But anyway, from an exam point of view, I would say this is sinus rhythm, right axis deviation, diffuse T-wave abnormalities, and loss of R waves anteriorly, even though there's no QS complex here, but there's no box for checking loss of wave. You can say it could be old anteroseptal myocardial infarction, but these T-wave changes are suggestive of ischemia. Now, let's look at the various morphologies that we might see with reference to the T-waves and whether they are specific or non-specific. These are the non-specific type of T-wave changes. This is a normal T-wave. We have a horizontal ST segment and a symmetrical upright and downslope T-wave. This is a biphasic T-wave, which is a sort of non-specific. We have a biphasic, like a double hump. Then we have sort of a diffuse flat T-wave, of course, and a flat T-wave. And sometimes we can have minor inversion of the T-wave, like tiny inversion of the T-wave. And these are the ones, this is related to hyperkalemia with the ST elevation and the hyperacute T-waves, repolarized abnormalities where we have ST elevation and prominent T-waves. Ischemia is associated with ST elevation and T-wave inversion. Left ventricular strain is associated with the J-point depression, downsloping ST segment, and biphasic or inverted T-waves, and prolonged QT interval, which is related to either congenital heart disease or most often related to the drugs. Okay, here what do we have? We have a sinus rhythm here, low QRS voltage in the limb leads, and we have left atrial enlargement or abnormality. We have right bundle branch block. We have QS complexes V1 to V4, suggestive for anteroseptal myocardial infarction. We have an acute STT changes suggestive for myocardial injury. That's the one we need to circle. STT changes related to myocardial injury. So this is a case of an acute myocardial infarction. Since this patient has already developed Q waves, this myocardial infarction is greater than 6 to 8 hours older. And of course, some of the other things that is, it goes all the way up to the lateral wall, V4, V5. And so those are some of the things. There's a lot of things in this electrocardiogram, but so remember, we are not just interpreting the STT changes, we're interpreting the entire answer key sheet. So that's where I would mark as sinus rhythm, low QRS voltage in the limb leads, left atrial abnormality, anteroseptal myocardial infarction recent, right bundle branch block, and STT abnormalities suggesting myocardial injury. It's a lot in this EKG. And here we have an electrocardiogram which looks kind of pretty sick. Whenever you see an electrocardiogram that is pretty sick, you should always think about what is the underlying condition. What this I can say is like a 55-year-old hypertensive patient on dialysis who missed 2 dialyses. That should be a tip-off. This is a patient with hyperacute T waves suggestive of a hyperkalemia. And when you're talking about hyperkalemia, notice that there is widening of the QRS complex, then tall peaked P waves. There's also going to be the loss of P waves with elevated higher levels of potassium, wide QRS complex, and eventually we'll end up seeing what looks like a sine wave. Next, we have an electrocardiogram with evidence of left ventricular hypertrophy by voltage criteria here. This is 10, 11. So there is evidence of left ventricular hypertrophy, and along with that we have a J-point depression, downsloping ST segment, and biphasic T waves. So left ventricular hypertrophy with strain. And we also have left axis deviation and left anterior hemiblock, and the underlying rhythm is a sinus bradycardia. It's less than 60. So we have sinus bradycardia, left axis deviation, left anterior hemiblock, left ventricular hypertrophy with the strain, and along with that, the PR interval, the QRS interval is greater than like 100 milliseconds. So I would also put in intraventricular conduction delay. So those are some of the things which I see. If you see anything else, please do make a note in the comments. And this is an electrocardiogram which is showing a sort of a sinus rhythm here, and as you can see, there's more or less low voltage, except this one has more than 5 millivolts, but you can't write low voltage here. But look at the T waves, they're flat, they're kind of flat or biphasic. So these are non-specific T wave changes, and you have to just understand, watch them, see them, maybe watch this video several times, then you get familiar with it. And here's an example of a 65-year-old male with history of arrhythmia on sotalol. We can't get any more better trip than this. Whenever patients are on antiarrhythmics, you should know the mechanism of action of these antiarrhythmics as a cardiology fellow or as a cardiologist. And antiarrhythmics, especially sotalol and other drugs, prolonged QT interval. And here, what are we looking at it? We have a prolonged QT interval. Along with that, there is STT deformity, and here we have ST depression. So we have bradycardia, 1, 2, 3, 4, 5, 6. We have bradycardia less than 60. We have, is this sinus? Let's determine this. I don't see definite P waves. So there is a P wave here, but there's only one P wave there. So I don't see definite P waves. So this looks like could be a escape junctional rhythm with STT abnormalities, which can be related to the drug and prolonged QT interval. Let's look at another example. Compared to the previous one, at least we see some definite P waves here, and this is again sinus bradycardia. And we have sinus bradycardia here. Let's go down as we see. There's some T wave inversions here. And the T wave, the main thing is the QT interval is prolonged. Whenever we see a QT interval prolonged, we always need to think about is this related to an underlying heart disease, or is this related to a drug this patient may be receiving? Since this patient has a history of heart failure, maybe has got some arrhythmias and maybe on antiarrhythmics, in that case, we need to be concerned about the QT interval. When we are talking about QT interval, we have to use the corrected QT interval based on the heart rate, and that is a different chapter altogether. Please do look up that, because that's an important factor to take into consideration. All right, let's look at this. Here we have a sinus rhythm, and there's a little bump here. It's not bifid T waves because these are prominent U waves. What are the conditions we see prominent U waves? The first thing that comes to our mind is hypokalemia, but there are a lot of other conditions that can cause U waves. Do we see anything else in this electrocardiogram? There's a low voltage here, but not in the rest of the leads. The anterior region looks okay, the lateral region looks okay, the STT look all right. So this is a case of a prominent U waves. And here's a chart that shows various conditions that can give rise to prominent U waves. Sinus bradycardia can give rise to prominent U waves. Hypokalemia is an important condition where we can see higher U waves. Hypothermia, drugs like quinidine, type 1 antiarrhythmics, CNS disorders, long QT syndrome, left ventricular hypertrophy, mitral valve prolapse can sometimes, and hypothyroidism. So these are some of the conditions that we need to keep in mind. So there could be something in the history that might suggest one of these points, and that's why you need to connect the history whenever you're reading at the EKGs and you don't know what exactly you're looking at. Okay, here we have a patient with a history of palpitations and dizziness. So what do we see here? Here, first of all, we have a heart rate which is like, it's not 300, it's like 260. So this is a pretty fast heart rate. Now, narrow QRS complex, it most likely looks like atrial flutter with one-to-one conduction to me, along with significant ST depression suggestive of subendocardial ischemia. Once we slow down the rate, the ST segment may return back to normal. So the ST segment depression may be related to just reduced diastolic filling period, reduced coronary perfusion, and this may be just rate related. But nonetheless, the ST depression, horizontal ST depression, is suggestive of subendocardial ischemia. And along with that, we also have what looks to me like atrial flutter with almost one-to-one conduction. And let's talk about some T wave changes, STT changes, QRS changes we see with hypokalemia and hyperkalemia. When the potassium level drops, we see flattening of the T waves, development of U waves, and then as it goes further, the T waves become flat, they can become biphasic, and when the potassium level is 1.7, you see the drop in the J point and a biphasic T wave. On the other hand, with hyperkalemia, we begin to see tall peaked P waves. Again, there's a drop in the J point with the peak T waves. Then there's widening of the QRS complex. Eventually, it leads to like a sine wave when it goes beyond 8 or 9 milli equivalents per deciliter. So, ladies and gentlemen, this is a very quick summary of ST, T, and U wave abnormalities. Thank you so much for watching this presentation. You can get a free copy of this cardiology rotations manual with more than 250 pages of very useful information. Please send me an email to drniknikam@gmail.com. Let me know what part of the world you are from and what is your specialty and how this manual would be useful to you. And please do subscribe to our YouTube channel, and please do tell your friends to subscribe to our YouTube channel and make use of all these free educational seminars. I will see you in the next presentation. Thank you so much.